Good afternoon. At the end of the session, the students should be able to appropriately manage the common sexually transmitted infections, or STIs. For the outline of this talk, I'll give you a brief overview of this problem or this condition, and I'll be presenting each of the sexually transmitted infections presenting as discharges or ulcers, then move to pelvic inflammatory disease and epididymitis. Now, the examination questions are not limited to this presentation, so students are requested to read the latest edition of Harrison's, the 22nd edition, Chapter 141. In the approach to handling individuals with sexually transmitted infections, it's quite important for all of us to know how to prevent and control its acquisition as well as its spread to other individuals. And usually, we need to know different factors that interplay in terms of how it's actually transmitted or acquired, how it's spread to others, and what are the modulating or intensifying factors why there is ease in the transmission of these particular agents causing sexually transmitted infections. So we need to, of course, know uh, that the rate of sexually transmitted infection is definitely related to sexual exposure of susceptible individuals to infectious people. So we, of course, know that those who are promiscuous are more prone to develop sexually transmitted infections, more so if they're not familiar with, of course, whether that particular agent whom you're having sex with is infected or not. And therefore, to prevent acquiring or transmission of sexually transmitted infections, it's actually our job to advocate, um, um, make that advocate good behavioral patterns in terms of sexual activities. In fact, we need to change, or we need to be active in terms of changing any sexual abnormal sexual behavior norms. And I say norms because it's quite frequent. Alam natin na maraming mahilig. And of course, with this measure, we can reduce the proportion of the population getting infected. Now, another important factor is the efficiency of transmission for exposure. And certainly, if we are engaging too much on unprotected sex, particularly with individuals whom we don't really know, definitely that can facilitate the entry or the acquisition of this sexually transmitted agent. And therefore, to prevent this, certainly we must actually advise individuals to wear protective methods or use condoms and practice safer sexual practices. If possible, when we talk about other sexually transmitted infections that can be prevented by vaccines, certainly we must also advocate the use of these effective vaccines. And of course, among males, medical circumcision certainly would of course help prevent the acquisition of warts or other sexually transmitted infections. And last, of course, important factor is the length or duration of infectivity of those individuals who are infected with the sexually transmitted agent. Siyempre, pagka asymptomatic, hindi natin alam. And therefore, that's the reason why we have to advocate safer sexual practices. However, of course, if the patient is symptomatic, the longer duration, certainly the higher degree of these individuals transferring these sexually transmitted agents. And therefore, for both symptomatic and asymptomatic individuals, early diagnosis is a must. In fact, we advise those who are actively engaging in unprotected sexual behaviors to get checked or screened for these sexually transmitted infections, not only for HIV, which I'll be discussing later, but also more to provide cure and help, stopping the spread of these sexually transmitted agents. And therefore, by providing cure, we will stop the transmission of the agent, but we just have to make sure that our patients or those individuals will be advised on, again, avoiding any unprotected sexual activity and wearing protective measures, including condoms for males. And there are occasions when there is, of course, repeated or recurring problems with sexually transmitted infections, suppressive treatment might be necessary. Now, risk assessment guides detection and interpretation of symptoms that could denote a sexually transmitted disease. Decisions on screening or prophylactic preventive treatment, risk reduction counseling intervention like hepatitis B vaccination, treatment of partners of patients with known infections, and behavioral risk reduction by the patient. So consideration of routine demographic data, for example, the gender, the age, the area of residence is a simple first step in the risk assessment. Siyempre, do sa mga areas na maraming sexually active individuals, or I should say, the commercial sex workers, certainly we must always bear in mind that they need to be screened, more aggressively than those who have lower risk. And of course, in the latest edition, Table 141 3 provides a set of 11 STD HIV risk assessment questions that clinicians can pose verbally. And this guide will also give somehow leeway or permission to discuss topics that might be difficult for the patient to disclose. Now, part of our course job is to evaluate our patient and clinical assess whether they are um, infected and therefore needs immediate treatment. And certainly, again, we need to diagnose them immediately and screen them with other sexually transmitted agents. Tandaan nyo lang, with unprotected sexual activity, it's not just one, two, three, even more, sexually transmitted agents that can be acquired, if the patient continues to be engaged in unprotected sexual activities. And therefore, the treatment, the holistic approach of treating all by the syndromic approach can be done. However, we must bear in mind that we also need to address other sexually transmitted agents that can be determined by screening or by testing the other agents as well. And again, part of our job is to help prevent uh, the transfer, the acquisition, and the spread of the sexually transmitted agents. So for the sexually transmitted infection care and management, there are 5 arms. First, again, there is assessment. And during this time, we, of course, do the detection, interpretation of symptoms that, again, could denote sexually transmitted infections. Tandaan nyo lang lagi, ask for the sexual activity. And again, there's a way for all of us to become familiar with how will become more open, or we can actually develop that rapport, or somehow make sure that our patients would not be hesitant in telling you valuable information that will help you in terms of handling your patient. And then and during this time, of course, we decide on what other uh, sexually transmitted infections to screen or test. And later on, we also need to know how to advise prophylactic measures. And we also need to learn, of course, how to reduce the risk of these individuals from getting any STI. And this is one of the important inventions that we can do. And definitely, we must also remember to address the partner of our patients. We should not forget them, because the partners can also facilitate the transfer of these agents to other individuals. So, hindi lang doon sa pasyente nyo. And that's overall will be part of the behavioral risk reduction. So not only your patient, but also the patient's partner. So this is a table that can be seen in the Harrison's Principles of Internal Medicine. And as I mentioned earlier, there is a framing statement that will guide you in terms of how you can somehow encourage or make your patient be more open in telling you uh, what could be the patient, what could be his symptoms, what could be her other manifestations, and this will certainly help you understand what's happening to your patient, and definitely also make you more familiar with what type of infections the patient could be having. And also this will help you, in terms of discussing, the sexual behavior of the patient. Because pag natutunan nyo to, mas madali. Hindi kayo mahirapan in terms of getting more information. That could be vital, in handling your patients. So moving to the screening questions. First question, do you have any reason to think you might have a sexually transmitted infection? So if so, what's the reason? So tatanungin na, ano ba yung risk? Ano ba yung ginawa mo the other day or last week? Meron ka ba nakasama na hindi mo masyadong kakilala? Yung nagkita lang kayo, tapos biglang nagkasundo that you'll have sex. And then, of course, for adolescents less than 18 years old, siyempre tatanungin na rin, have you begun having any kind of sex yet? So, dapat hindi tayo marunong mahiya, and that's quite important when we are handling a patient, suspected to have a STI. Now, third, have you ever had any sexual transmitted infections or any genital infections? So, tatanungin mo na. Pag sinabi kasi nilang posible sila may sexually transmitted infection, dapat magkaroon agad kayo ng idea na, baka nagkaroon na to dati. Kaya, kailangan tanongin niyo rin, nagkaroon ka na ba dati? Kasi kung nagkaroon ka na, ano ba yun? And then, number 4, have you had sex with men, women, or both? So right now, alam na natin, medyo liberal na. In fact, because of the ease in contacting through the internet, yung mga Wi-Fi messages, yung mga internet messages, or should I say the messages that we send, to our potential partners via the internet now are quite easy. Therefore, even yung meeting up with other persons is much much easier now than before. And then, of course, also important, to add to make sure that the patient doesn't have any other risk factor like injection drug use. So number 5, have you ever injected yourself with drugs? If yes, have you ever shared needles or injection equipment? So contamination per se can pose another risk, for a sexually transmitted agent. Have you ever had sex with anyone who had ever injected drugs? So, pati yung partner, kailangan tanungin nyo rin, I mean, kung hindi present yung partner, then that patient should also be asked about the possibility of his or her partner getting engaged with prohibited drugs that are acquired or that are obtained, by injections. 7, look at the characteristic of the partner. Have any of your sex partners had any sexually transmitted infections? Siyempre, again, huwag kakalimutan ng partner. Have any of your sex partners had other sex partners during the time you've been together? Now, moving to the symptoms checklist, have you recently developed any of these symptoms? For men, discharge of pus or drip from penis, or genital sores or rash, or even pain in the inguinal area, or sometimes, of course, rashes. Now, for women, abnormal vaginal discharge, was there noted increase in amount, abnormal odor, abnormal yellow color, or even presence of sores or rashes or ulcers, or even itchiness? That's quite important because although candida can be present in us, however, this can also be facilitated, by the acquisition can be transferred by sexual activity. Now, for sexual practices, past 2 months, for patients answering yes to any of the above questions, This will serve as a guide because you now can move to other parts, no? So, I'd like to ask what parts of your body have been sexually exposed on STD. Remember, these agents, I'm sure narinig niyo yung MPAX, no? Sikat na sikat yan eh. Kasi na-stigmatize sa mga HIV or even gay individuals because they were frequently seen, no, in this group of patients also who have been infected with HIV, primarily because of intimate contact. And therefore, even the hands or fingers na other areas distant, no, to the genital areas can actually acquire sexually transmitted agents, even the mouth, of course. Now, you also need to inquire about the interest in STD screening tests after, of course, running down all the symptoms because there are, again, sexually transmitted agents that may not present with any symptom, like hepatitis B or even syphilis, and therefore you might need to advise them on having this screening test, for such infectious agents, because you also need to explore the possibility of other sexually transmitted diseases. So moving to the clinical assessment, again, going back to your patient, assess the presence of symptoms and signs of sexually transmitted diseases. So don't limit yourself on the common agents. Sometimes patient may present with arthritis, even if they don't have any drip or any discharge, baka naman gonococcal arthritis na yan. No? So it's quite important to also elicit other information aside from just the usual or the common manifestations of STD. Now, moving to diagnostic testing or screening, of course, once you have done the screening test and it turns out to be positive, then you have to confirm this test. So for example, when we talk about syphilis, usually we do the RPR to screen for syphilis, and to confirm it, you can actually request for FTA-ABS or the TPPA. Or these are confirmatory tests that will tell you that the patient indeed has syphilis. Because there could be false positive reactions of RPR, including patients with lupus, and therefore you have to do some confirmatory tests. There are, of course, other uh, good tests now that are available, including, of course, the nucleic acid amplification test, the PCR, that can rapidly diagnose your patients to have either Neisseria gonorrhea or Chlamydia trachomatis infections. So you do all of this, of course, even uh, in individuals without any symptom, particularly those who are at higher risk, meaning if they are sexually active, even if they don't have any symptom, you may opt to offer doing such screening tests to make sure that you're not missing anything, because the danger there, if you miss the diagnosis, that individual, if he continues to engage with unprotected sex, then there's this risk of transferring those agents to other individuals that are susceptible. Moving to the fourth arm, of course, syndromic treatment. Madalas, pagka discharge, it's not only treating for Neisseria gonorrhea, but also for the non-gonorrheal pathogens. So even if, for example, you're not able to do the PCR tests or the NAAT for such infections, it's usually syndromic in terms of treating your patients. So you give ceftriaxone plus azithromycin to cover for both gonorrhea as well as the non-gonococcal pathogens. But of course, because of the increasing resistance rate of Neisseria gonorrhea for azithromycin, if there's a higher likelihood of Neisseria gonorrhea, there are now options to give doxycycline, particularly if you would like to cover for other atypical or unusual non-gonococcal pathogens like Mycoplasma and Uroplasma. Gonococcycline might be a more effective drug ng azithromycin. Remember, similar to other antibiotics, even these organisms can develop resistance if that individual has been frequently taking these drugs because of repeated or recurring sexually transmitted infections. For women, of course, you may need to, of course, check for the vaginal fluid, whether you're just dealing with bacterial vaginosis, or sometimes you may be dealing with trichomoniasis. or even worse with the pelvic inflammatory disease that is usually due to sexually transmitted agents. And sometimes gram stain can be useful, but because of the availability of the rapid tests, no, PCR or not can be a more valuable tool. No? Rapid plasma reagent test, an RPR, no, can help no, assess the presence of painless genital ulcer to know whether it's due to syphilis or not. No? Pag painful, usually yung ulcer, syphilis yung dahilan. I'm sorry, not syphilis. Pag painless, it's syphilis. But it's painful, usually it's herpes. Okay? Again, painless, syphilis, painful, herpes. Now, moving to prevention and control, remember the 4 C's. First, contact tracing. Importante talaga yan. No? Pagka may dumating sa inyo na pasyente at merong symptoms, then try to investigate kanino niya nakuha. Try to know how you can address this particular partner because it's quite important to stop or halt, of course, the spread of this disease. And second is compliance with therapy. Usually, single dose naman niya pagka gonorrhea or non-gonococcal. Pag syphilis kasi, depende kung anong type of syphilis. No? Usually, it's primary, secondary, tertiary. Pag late latent syphilis, usually you now require 3 doses no, of the injectable penicillin. Unlike for primary, secondary, and early latent syphilis, which is just single dose of benzodiazepine penicillin. Now, it's, of course, counseling is important to reduce the risks, and it's quite important really to learn how to interview, to talk to this kind of patients. And last, but of course, part of the important preventive measure is the use of condom. No? To promote this use, to promote sexual safety sexual practices. No? And ako, meron akong condom na binibigay, offer sa mga pasyente ko to help prevent the acquisition of another sexually transmitted infection, or even for HIV patients, I also offer them to prevent getting a mutant or as a different strain of the HIV virus or the HIV. Moving to STIs that present as discharges. For urethritis in men, the symptoms include urethral discharge, dysuria, sometimes yung isa lang, pwedeng both, usually without urinary frequency. Usual causes, madalas, chlamydia trachomatis, and usually the symptoms would occur at least a week after. Within a week, usually na gonorrhea, but it's quite difficult really to know which one of the two is present. That's the reason why the treatment is syndromic. No? And the other possible causes of urethritis includes mycoplasma, uroplasma, trichomonas, and even HSB, primarily because of the pain. There could be some inflammation producing clear discharge. Now, in the States, neither oral cephalosporins nor fluoroquinolones are recommended for treatment of gonorrhea because of the emergence of increasing fluoroquinolone resistance, especially among men who have sex with men. And decreasing severity with still small proportion of gonococci to ceftriaxone. Now, in men, the diagnosis of trichomonas vaginalis infection requires nucleic acid amplification testing of urethral swab specimen obtained before voiding. Mycoplasma genitalium is often resistant to doxycycline and azithromycin, but it's susceptible to fluoroquinolone moxifloxacin. Moxifloxacin can be considered for treatment of refractory non-gonococcal non-chlamydial urethritis. So it's quite important for all of you to become familiar with prevailing resistance patterns in the local setting. In the Philippines, still very susceptible to ceftriaxone ang Neisseria gonorrhea. Azithromycin still doesn't have any problem, but again, because of the other non-gonococcal pathogens, doxycycline can be a good alternative, but ang problema sa doxycycline, it has to be given or taken by the patient for 7 days. So in the initial evaluation, certainly you have to, of course, really make sure that there is urethral discharge. If you can do testing and check for presence of pus cells, then you can request for your analysis. But it may no longer important for as long as you have seen discharge or urethral discharge in the initial evaluation. Of course, you need to exclude local systemic complications, and again, you can perform gram stain or do uh, NAAT test or NAA test or nucleic acid amplification test. Um, Again, use ceftriaxone plus no, azithromycin or doxycycline, okay, for the treatment. No? Now, sexual partners who contact the expression in the past 6 days also test for gonorrhea and chlamydial infection. Regardless of whether they're tested for these infections, they still need to receive same regimen given to the male index case. And vice versa. Kung yung babae nagkaroon ng ganyang sakit, siyempre yung partner ng lalaki gagamutin din. That's what we call as epidemiologic approach in treating such cases or conditions. Now, for T. vaginalis infection, NAAT, intraurethral swab specimen, or first voided urine sample, you may actually give metronidazole, a 2 grams single dose by the mouth. Now, in women, of course, there is what we term as urethral syndrome, where there could be some internal dysuria, with or without pyuria, or with or without urinary urgency or frequency, and there's absence of E. coli or other uropathogens at 10 squared per ml of the urine. And most of the time, this is due to chlamydia trachomatis and or Neisseria gonorrhea. However, if there's external dysuria, painful contact of urine with the inflamed or ulcerated labia or introitus, so ibig sabihin, affected yung vaginal wall, there could be much more, there could be an expansion or there could be spread inside the vaginal wall. And therefore, you have to entertain the possibility of HSV. If there's itchiness, then think of Candida. If there's foul-smelling odor, then think of Trichomonas vaginalis. Now, for a single urinary pathogen, for example, E. coli, Staphylococcus saprophyticus, at a concentration of at least 10 squared per ml in a properly collected specimen of midstream urine. Pag sabi midstream, dapat marunong din kayo magbigay ng instruction on how to collect the sample. Kailangan yung gitnang ihi, hindi pwedeng mag-umpisa, hindi rin magtatapos, because that can actually be contaminated by the organisms surrounding that area. And therefore, if this is present, bacterial UTI could be the reason why this patient is having dysuria. But if there is pyuria with less than 10 squared conventional urine pathogens per ml of urine, that could be sterile pyuria. But then again, go back. If the patient is sexually active and there is unprotected sexual activity recently, and the individual doesn't really know too much her partner or her previous partner, then again, think of this syndromic approach, and therefore that female partner or that female patient should receive the treatment for both Neisseria gonorrhea and chlamydia trachomatis. Now, moving to vulvovaginal discharge. So remember that this can be problematic for female patients, regardless whether they are sexually active or not, because there are conditions that might not be sexually transmitted, but primarily because of hygiene, and that's a common thing, particularly in some areas, with there are problems in terms of the supply of water, as well as the hygienic practices are not good, and therefore you also need to entertain other possible reasons why there are discharge expanding in the vulvovaginal area. Now, if the patient presents with itching, again, ulitin ko, most of the times usually due to fungus or candida. And on examination, as you will see in this picture, there are white clamped adherence plaques in the vaginal wall. And usually, there is erythema of vaginal epithelium, introitus, and again, there could be some form of itchiness, there could be vulvar dermatitis, and in fact, there could be some fissures that can be seen. Now, for this one, of course, then you have to entertain the possibility of fungal or vulvovaginal candidiasis. For trichomonal vaginitis, due to Trichomonas vaginalis, the discharge is more profuse, and aside from, of course, the itchiness in the vulval area. In contrast, the discharges are white, yellow, and homogeneous, not that white clumping adherent plaque seen in candidiasis. And similar to candidiasis, there's also erythema of the vaginal bulbar epithelium. And of course, for bacterial vaginosis, which is can be due to Gardnerella vaginalis and other anaerobe bacteria, ito yung mabaho. No? So that can be easily identified in these individuals because of foul smelling odor of the discharge, and usually the discharge is grayish. No? And it uniformly coats the vaginal wall. And there's no sign of inflammation or erythema in the vaginal wall. Now, if you check the pH, usually if it's less than 4.5, it's candidiasis, but if it's more than 4.5 or at least 5, it's either vaginosis or trichomonal vaginitis. If there are leukocytes, mycelia or mycelia by microscopy, then you might again you would have to consider candidiasis. You will no longer need to isolate the candida because usually it's already sensitive, to fluconazole or most of the time it's candida albicans. No? Now for vaginitis or trichomonal vaginitis, there are a lot of leukocytes. There you'll be able to appreciate the motile trichomonads, particularly among symptomatic patients. Now, for vaginosis, the typical or the pathognomonic sign is the presence of glue cells, aside, of course, from the fishy odor, because to start with, it's malodorous. No? And usually, again, there's no lactobacilli or few leukocytes, um, and it's quite really difficult to see any organism. Most of the time it's negative, except of course if there are organisms that are causing it, including Gardnerella vaginalis and under anaerobic species. And the best really to know the organism is doing the NAAT, the nucleic acid amplification test. For the treatment, candidiasis, as I've said, fluconazole could be the most helpful because it's single dose. Miconazole, 100 milligram vaginal suppository can also be given, or clotrimazole for 7 days. Um, Now, for the partner, kung may contact dermatitis yung penis, then definitely you also need to advise treatment. Can be fluconazole, but topical treatment, with antifungal like clotrimazole can also be given to the partner. For trichomolar vaginitis, metronidazole. Now, for bacterial vaginosis, same. However, kung single dose at trichomoniasis, sa bacterial vaginosis, it should be 7 days. But you can also provide metronidazole gel or using clindamycin 2% cream, as alternative treatment. For the partner, again, sabi ko nga, meron dito kasing hindi mas sexually transmitted like bacterial vaginosis, pwedeng hindi mo nagamutin. But for trichomoniasis, siyempre, i-treat mo rin yung partner because that can also be sexually acquired by the male partner. Moving up, we have the cervicitis, and most of the time, this is due, of course, to a sexually transmitted agent. There is inflammation of the columnar epithelium, subepithelium of the endocervix, or any contiguous columnar epithelium of the ectocervix. Usually, of course, this is the diagnosis done by the gynecologist. But the cardinal signs of diagnosis include yellow mucopurulent discharge or cervical os or endocervical bleeding upon gentle swabbing and edematous cervical ectopy. Presumptive treatment with antibiotics active against Saccharomyces trachomatis like doxycycline or azithromycin should be provided for women at risk. Of course, fluoroquinolones in the US can also be an option. Now, certainly it's recommended to have asymptomatic individuals or high risk, um, to be screened, for chlamydia and gonorrhea because you don't want these individuals to develop the disease, and you don't want them to get pregnant because of the risk of to the fetus as well as to to the baby, especially if they are already in term delivery or in the last term of their pregnancy. Pagka asymptomatic na healthy, na hindi naman high risk, no need to routine screening. And this, of course, based on the Philippine guidelines, periodic health examination. Okay. Other high-risk population include men with HIV, non-monogamous relationship without condom use, age less than 25 years with 2 or more sexual partners in the past year, sex partner active or previous STI, with previous or coexisting STI, doubting within the past year, commercial sex workers, and cervical ectopy. Now, moving to sexually transmitted infections that present as ulcers. So remember, painless syphilis yan. Pag painful, herpes. That's the way to distinguish the two. And usually pag herpes multiple, pagka syphilis single. No? And the diameter is usually larger for syphilis. Pagka herpes, before they become vesicular, before they get eroded, usually they are too small. No? And usually the background or the borders are erythematous. Unlike, of course, the edges, while the edge for syphilis is sharply demarcated, no? Kasi pag nag-erode na siya sa herpes, medyo mas eroded din, no? Pag depth naman ng syphilis, usually superficial or deep, but these are painless again. Pagka herpes, kahit superficial, they are painful, no? Now, for chancroid, no, usually they present with pustule, usually multiple may coalesce, and ragged, irregular edges, and most of the time, these are excavated, mas pangit ang itsura nila. Now, if you go up again to the incubation period, longer syphilis, kaya sometimes the patient may not present immediately with the painless ulcer. Sometimes ini-ignore nila kasi wala ngang pain eh. Mawawala na lang yan, gagaling ng kusa. No? That can actually resolve spontaneously. However, they are at risk of developing secondary syphilis later on. In contrast, pag herpes, mas mabilis ang incubation period, less than a week. No? Pag chancroid, it can extend up to 2 weeks. Okay? So these are the 3 common genital ulcers that we see. Most of the time, it's herpes. Now, recently, there's a surge or there's an increased number of syphilis that we saw, not only among HIV infected individuals, but even to non-HIV infected individuals. So, chancroid is less common among the 3. However, if it's actually irregular, ragged, excavated, and initially presenting pustule, then think of chancroid as a more likely possibility. Now, lymphogranuloma venereum, usually the incubation period is 3 days up to 6 weeks. They may present with either papule, pustule, or vesicle. So any time, any kind of primary lesion as to the 3, but usually just one, often not detected despite lymphadenopathy. So madalas wala eh. Madalas lymphadenopathy na lang, no? And usually, kung meron man, the edges are elevated, round or oval, and of course, the depth is superficial or deep, no? Depending whether it's present or not, no? For donobanosis, 1 to 4 weeks incubation can be up to 6 months. They will present usually with papule. The number of lesions is variable, same with the diameter, but similar to lymphogranuloma venereum, usually the edges are elevated, but can be irregular, but the depth is elevated. No? Now, to differentiate the 5, yung base naman, pag syphilis mute, non-purulent, relatively non-vascular. Pag herpes, serous, erythematous, non-vascular. Chancroid, purulent, bleeds easily. Lymphogranuloma variable, non-vascular, and therefore non-bleeding. Pagka donobanosis, red, velvety, bleeds easily. That's the way to differentiate the last 2. No? Pag chancroid, ulitin ko, pangit ang itsura nila, and usually they're purulent at madaling magdugo. No? Pag syphilis, if it's present, usually the induration is firm. Pag herpes, none, no induration. Chancroid, soft, occasionally firm for lymphogranuloma venereum, firm for donobanosis. Now, ulitin ko, syphilis, painless. No? Herpes, painful. Chancroid, usually very tender, Very tender, especially when you touch it. Lymphogranuloma venereum variable, donopanosis uncommon. Now, lymphadenopathy may not be present in all, but usually it's present with syphilis, sometimes with herpes. No, for chancroid, it can be tender, may suppurate. No, usually unilateral. For lymphogranuloma venereum, same as chancroid, there are tender suppuration of the lymphadenopathy. For donopanosis, none. Usually, they've been just present with pseudobulbous. For the initial assessment, no, you can perform dark field examination if available, or again, RPR, VDRL for screening, and you can actually do TPPA or FTA-ABS to confirm. No? But if there's an ulcer, you can also do direct fluorescent antibody test or PCR to check for T pallidum. No? Now, culture might not be necessary for HSP. Pag nakakita lang kayo ng mga ulcerated lesions, yung maliliit, no, and usually it's painful, usually you can already clinically diagnose it as having herpes. No? And the problem with herpes, it recurs. No? Even if you become celibate, no? Maulit yan. Nasa inyo na yan pag nagkaroon kayo ng herpes. No? Now, in Chancroid endemic area, PCR culture for Haemophilus ducreyi. No? Initial treatment, ito na. These are the recommended drugs sa beer family. Cyclopam, for herpes, for syphilis, as I've said earlier, benzathine, penicillin. You also need to consider treating the partner because you don't know if that syphilis has been acquired several years ago, if it's already latent. No? Now for chancroid, fluoroquinolone, ceftriaxone, or azithromycin. So ito yung picture ng syphilis. No? Sabi ko nga kanina, malalaki siya, tapos broad, no, painless yan. And for secondary syphilis, most of the time, much more prominent in the palms and soles. No? And usually they present with papular lesions. No? They can be maculopapular, they can be generalized, and beware because they are highly infective. So if you shake your hand, if they shake your hand, bigla kayo may nakapa, magulat kayo, baka magkaroon din kayo sa kamay niyo. Okay? But these are highly infectious agents. So, so let me run through the course of syphilis. No? So when you get infected, you will develop primary syphilis after 2 to 6 weeks after getting it from somebody who is infected. And usually it would present with chancre, and that can be labeled as primary syphilis, with or without regional lymphadenopathy. And of course, if it doesn't get treated, it can proceed, no, to secondary syphilis 1 to 2 months after. Concurrent chancre and RAS are seen. I mean, they can coexist, in roughly around 9% of cases. Now, for secondary syphilis, madalas nga ito yung mga maculopapular rashes generalized, no, but more prominent in soles and palms. And usually they can present with general lymphadenopathy. Some would present with fever. Some would present with mucosal lesions. Just check, of course, the oral area, oral cavity. And some may present with alopecia as well, along with other organ involvement, hepatitis, and nephritis. No? And of course, if they are not treated, then they can proceed to early latent, later on with late latent. So the difference is less than a year after infection, early latent, at least a year after that can be late latent, and both are asymptomatic. Now, in some individuals, like those with HIV, they can actually have recurrence of secondary syphilis. Ulitin ko yung kanina sinabi ko, no? Ingatan nyo. Pag nagsuspect ka na may syphilis, ingatan yung kamay na yan, no? Because that can actually cause some problems on you. No? These are highly infective or infectious areas, no? Among those who have syphilis or secondary syphilis. Now, of course, in some individuals, particularly HIV, they, from the very start, no, they may already have, no, neurosyphilis because of CNS invasion, and that's quite common again among those immunosuppressed, particularly HIV, and that can actually be the main manifestation of AIDS already in patients who are not diagnosed to have HIV before. No? Now, there are occasions that early neurosyphilis can be seen among asymptomatic individuals. However, if they are symptomatic, they can be either meningeal or meningovascular. And usually, if the affected area is usually the cranial nerves, no? And most of the time, there could be some form of ocular syphilis or otic syphilis, no? And for meningovascular syphilis, um, they may present no later, no, and they can present with similar to stroke. No, there could be hemiplegia, aphasia, and even with seizures. No, and in some occasions they will present with late neurosyphilis and same manifestations. No, they can present with stroke, and worst cases they may present with general paresis as well as tabes dorsalis, that include lightning pains, ataxia, blood disturbances, visceral crisis, and rectal incontinence. So that's how severe late neurosyphilis is, particularly with those meningovascular disease. Now, some late latent may also present with tertiary syphilis, and usually we see this in the elderly age group, no? And before HIV, there are already reported cases of this, but for individuals with HIV or those who are immunosuppressed, much more common are the neurosyphilis or even the meningovascular disease. So for tertiary, can be gummatous, cardiovascular, even ocular and otic syphilis, as a late manifestation of tertiary syphilis, and this could occur at least 15 years after getting the primary infection. So, serologic tests are non-reactive in up to 30% of persons with primary syphilis, and testing should therefore be repeated in 2 weeks if the initial test result is non-reactive, especially if you're highly suspecting it. Pag clinical kasi, pwede mo diagnose talaga. Pag painless ulcer na talagang chancre ang tsura. Now, non-treponemal test types often decline rapidly after treatment but may also decline all the more slowly in the absence of treatment. Ito yung sinasabi ko na pwede naman talaga silang mawala because of our immune system. No? Treponemal tests remain reactive irrespective of treatment history, but up to 24% of patients treated in the early stage of syphilis and pure conversion years after therapy. Now, for neurosyphilis, there's no standard test. No? So, a combination of laboratory tests and clinical signs and symptoms um, are, is used. No? A reactive CSF non-treponemal test is highly predictive of neurosyphilis, although it's less than 80% sensitive. A CSF treponemal test can be sensitive, but it lacks specificity owing to passive transfer of serum treponemal IgG antibodies across a blood CSF barrier or to traces of blood in the CSF. So again, for the serologic testing for syphilis, traditional, cost-effective, especially for resource-limited settings, lack specificity, relies on subjective interpretation. For the reverse sequence, the treponemal test over the non-treponemal test, more efficient, labor-intensive, ability to detect early disease, high false positive rate in low prevalence populations, more expensive. Now, most of the time, this can confirm. However, matagal ang result ito eh. And that's the reason why we do non-serologic or non-treponemal testing as a screening test, no, for syphilis. So again, comparing the Sensi and Speci, for VDRL and RPR, almost the same Sensi, almost the same specificity. For FTA ABS, certainly quite sensitive, much more sensitive than the non-treponemal tests, no? But lower specificity. For TPPA, much higher sensitivity and much higher specificity compared with FDA ABS. So for the treatment, I mentioned about penicillin, but alternatively, you can give doxycycline or ceftriaxone. For neurosyphilis, ocular syphilis, usually IV penicillin. No, in pregnancy, definitely have to be treated because you want to prevent, of course, having the frequency of congenital syphilis. Now, lifted from the Philippine guidelines of periodic health examination, you can see that the target population is those are high risk as well, high risk individuals, both non-pregnant and pregnant, no, to screen for syphilis. No? For asymptomatic, apparently healthy, non-pregnant, then routine screening is not recommended. But for healthy pregnant, screening for syphilis still recommended as early as possible so that you would know whether the pregnant patient has syphilis or not and prevent the occurrence of congenital syphilis. Balik ako in high risk. Again, these are the HIV positive men, MSM, unprotected, those who are engaged in unprotected sex, those with contact with known case of syphilis, commercial sex workers, of course, those with history of sex in conjunction with illicit drug use, no? And of course, those who are sexually promiscuous. Moving to pelvic inflammatory disease, it's an infection that ascends from the cervix or vaginal to the endometrium, the fallopian tubes. The primary causes of endocervitis include the sexually transmitted agents, plus anaerobes associated bacterial vaginosis. Manifestations include endometritis, salpingitis, peripatitis, and parappendicitis. So, siguro na nababasa yun, narinig niyo yung Fitzhugh-Curtis syndrome. No? So, that's something that we see if there's already involvement of the liver as well as appendix. Serologic agents, as I mentioned, causes of sexually transmitted agents along with anaerobes. For the diagnosis, laparoscopy might be necessary to exclude other surgical problems. Endometrial biopsy can be done, while biopsy or swab specimen can be taken for nucleic acid amplification test to check for Neisseria gonorrhea, chlamydia, trachomatis. So the treatment, treat all. So ceftriaxone plus doxycycline plus metronidazole. So you should initiate parenteral therapy with those agents. No, if there's clinical improvement, then you can already shift to tablet and continue the outpatient therapy for 2 weeks. No? Now, most of the time, the individual is admitted to observe, check, of course, to make sure that the patient is pregnant or non-pregnant, and pelvic abscess has to be ruled out. And of course, if the patient is manifesting signs of severe infection or sepsis, then definitely you need to observe and of course check if the patient is responding properly or if the patient's fail is manifesting with some some signs that would reflect failure to treatment. So additional recommendation or alternative recommendations include cefotetan or cefoxitin. These are both with anaerobic coverage plus doxycycline. Another regimen could be clindamycin plus gentamicin that will cover again for all possible infecting agents that I mentioned earlier. Epididymitis. It usually presents with unilateral pain, swelling, tenderness of the epididymis with or without signs or symptoms of urethritis. The biggest problem is, of course, when the patient presents with sudden pain, elevation of testicle within the scrotal sac, rotation of epididymis from posterior to anterior position, or the absence of blood flow in Doppler ultrasound, and that can require surgical intervention or emergency intervention because there could already be testicular torsion. It also need You also need to rule out tumor or even extrapulmonary TB if the signs and symptoms persist, particularly the pain and swelling, despite therapy for epididymitis. Same pathogens, chlamydia trachomatis, Neisseria gonorrhoeae in older men in MSM or post-instrumentation. Think of the urinary pathogens also. Ito yung mga Enterobacteriaceae, including E. coli o Enterobacter. No? Uh, Treatment, subtaxone plus doxy. Pagka expect ng Enterobacteriaceae, then give fluoroquinolone, particularly levofloxacin. So, to summarize, and the important points that you need to remember in the approach to handling sexually transmitted infections, you need to recognize the syndromes, common presentations, urethral, vaginal discharge, genital ulcers, pelvic lower abdominal pain, and even adnogenital warts. Consider asymptomatic infections, especially in high-risk groups. That's the main reason why um, we advocate screening, particularly for high-risk individuals. Now, to diagnose effectively, usually syndromic approach in low resource setting, and therefore we treat, aggressively treat all, including the partners. Sometimes or most of the time, the nucleic acid amplification test is not available or even expensive. That's the reason why we just have to provide treatment to prevent continuing infection as well as the spread of this disease. Now, when available, then do the diagnostic test as necessary. Screen for co-infections, including HIV, hepatitis B and C, as well as syphilis. They may not present with any symptom. Therefore, they have to be screened for high-risk individuals. Treat promptly and appropriately. Use evidence-based guidelines. So we still utilize the WHO and CDC, although we now have the local health guidelines that we can refer to, particularly if we're dealing with some organisms that are still susceptible to the recommended drugs, unlike in the States. No? Again, treat empirically based on syndrome, ensure adherence and follow-up. Ito importante, kailangan talaga silang i-advise na pag-monitor. Importante na siguraduhin na mawala at siguradong hindi sila magkalat. So notify, treat, and counsel partners. You have to, of course, advise your patient to notify the partner and be treated also to reduce the risk and strategize in terms of how you can prevent the spread, control this particular sexually transmitted infection in the community or among themselves or sexually active. Therefore, safe sex counseling is a must. And vaccination should also be advocated for human papillomavirus and even hepatitis B. Now, you have to advise your patient to prevent recurrence, emphasize routine screening for high-risk populations, promote behavioral change, condom use, and regular testing, integrate sexually transmitted services with reproductive and HIV care. So these are the references of this presentation. I use the latest edition of Harrison's Research of Internal Medicine. Thank you, and I'll be moving to the next lecture, which is about HIV.